Welcome to ManagedCareHemo.com's question and answer session on hemophilia cost optimization and care coordination strategies. This program is jointly provided by the National Hemophilia Foundation, Medical Education Resources, and Impact Education, LLC, and it is supported by independent educational grants from BioMarin, CSL Behring, Sanofi Genzyme, Takeda, and Unicure, Inc., and we would like to thank them for their support. My name is Jim Kenney, and I am founder and president of JT Kenney, LLC, a managed care pharmacy consulting practice. Previously, I worked for Harvard Pilgrim Healthcare for 38 years in pharmacy management. I'm here today with Dr. Mark Redding, Associate Professor of Medicine and the Director of the Center for Bleeding and Clotting Disorders at the University of Minnesota Medical Center. We're going to answer audience questions we collected from our webcast about hemophilia care coordination and cost optimization. Our first question is, and I'll direct this to Dr. Redding, how has COVID-19 affected hemophilia treatment and care?
Yeah, that's the answer is obviously yes. It certainly has affected hemophilia treatment and care, as it's affected all aspects of our lives. Early on there were concerns about the potential for factor supply issues and shortages, and I'm happy to say that actually did not pan out to be an issue. We really have not seen any issues in that regard. So that's very, very reassuring. I think obviously the biggest impact of COVID-19 on our practice is the use of telemedicine. We've all converted to telemedicine early on. All of our visits were being done that way, and over the last several months, we've sort of slowly shifted back to doing more in-person visits. But at this point in time, certainly at our center, the majority of our visits are still being done via telemedicine. And I think that's been a good thing, more so than not. It has forced us to think about unique ways to connect with our patients, and I think we've actually come up with some ideas that may be lasting long beyond the pandemic. So I think overall it's been a good thing, even though it was a bit of a rocky start, perhaps. The other thing I would point out in terms of an impact of the pandemic on hemophilia treatment and care is the impact on clinical trials. Initially, clinical trial activity essentially came to a complete stop because of the stay-at-home orders and the impact on the institutions conducting these trials. Slowly, over the last several months, we've seen clinical trial activity, increase again, but it certainly has not gotten back to the place it was before the pandemic. And I think this is a big concern for all of us. We need these clinical trials to continue to develop new therapies and bring them to the market, hopefully. And so I think that's often an overlooked, but I think a very important impact of the pandemic on overall hemophilia treatment and care.
Great. Thank you, Dr. Redding. The next question is, how do patients living in rural areas manage their hemophilia?
Well, I think overall, those in rural areas, manage very similar to those living in urban areas. But historically, because of the distance that they are going to be from an HTC, historically, there's been less contact with the HTCs. I think that's a fair statement across the board. But again, here's where telemedicine has really been helpful. Our center's experience has been that because of the use of telemedicine now, which we were sort of forced to, now we've actually realized this is a really helpful tool for us to reach those patients that live a long distance from our center. And so our experience has been that we've actually had more contact with them. And I think that's a great thing. I guess the other major difference that I see between the patients that live, close to the center versus those that live in a rural area distant from the center is the importance for those rural patients, the importance of the center establishing contact with local providers. We try really hard to make sure that there's a local primary care provider that's involved in the patient's care. And those folks can often sort of be our eyes and ears if an assessment needs to be done and the patient isn't able to get to the center. We also often try to forge connections with the local emergency departments to make sure they know how to reach us if the patient shows up, make sure they have access to the tools they need to get the patient the care they need. So we have to do a few extra things for those patients. But again, I would really sort of focus on the beneficial impact of telemedicine on those patients living in rural areas as a very positive thing.
And I would add from the health plan perspective, certainly having the capability to get case managers involved that could also provide the telemedicine services, as well as we've seen with the COVID crisis, an expansion of coverage and making it easier for patients to access these types of services that may be available. So making sure that these patients who aren't local to some of the, the more comprehensive services do have the resources that they need to take care of their condition. Can you speak to some of the rationale behind why a provider or patient might choose on-demand treatment?
Oh yeah, that's a good question. I think there may be three categories that come to mind here for this question. Obviously there are patients that have a mild enough phenotype that they don't require prophylaxis, and those with mild hemophilia with a phenotype that doesn't require prophylaxis are going to be on default then on demand. So that's sort of the easy group to think about. There's another group though, and this tends to be the older generation. So patients born before the mid 1990s, when routine prophylaxis starting early in life became the standard of care. For patients born before that time, these are guys who did not grow up on prophylaxis. Many of them started prophylaxis later in life, but the concept of prophylaxis is not something that was integral to the management of their hemophilia from day one. And so those older patients often struggle with sort of buying into the concept of prophylaxis, even though we've got great data now that verifies the benefits of prophylaxis, even when started after the development of joint disease in adulthood. Many of the patients in that generation still have difficulty buying into this concept. Things that they often cite as reasons why they would prefer to stay on demand. Often they point to the cost factor. They're still concerned about issues with regard to cost and insurance caps and things that were a bigger issue in the past. Even though some of those things have been eliminated, the patients are still very mindful of that. In addition, a lot of patients in that generation, really tell us that they're satisfied with the status quo. They feel like the number of bleeds they have, even though we may feel like it's too many, they feel like they're doing okay. So that's definitely a group that we have some challenges with, and that may be the reason why they're choosing to remain on prophylaxis. The last group that I would maybe call out here, and this will sound a little counterintuitive, Jim, but we see some patients in the younger generation. So these are guys who did grow up on prophylaxis. They get through childhood and their teenage years, with very rare bleeding episodes. And we're starting to see some of these young men now transition to the adult clinic, questioning whether they really need prophylaxis, because their experience with their hemophilia has been that because prophylaxis has been so effective, they really haven't bled much. And then they start to question, do I really still need this? And some of that has to do with just the transition into adulthood and making their own decisions and taking more responsibility, for their own health care. But this is a group that we also have some struggles with. Some of these young men choose to go back to on-demand therapy, and need to sort of find out for themselves that prophylaxis is really what's best for them. So they're another group that may choose for a different set of reasons to treat on demand. Of course, our goal is always to get them converted back to prophylaxis, but oftentimes they have to figure that out for themselves.
Next question. What patient and disease-related characteristics are taken into consideration when choosing between a standard half-life factor replacement product and an extended half-life factor replacement product?
Oh gosh, there are a lot of variables here to consider. This is a very good question. Try to answer fairly concisely here. I think the first place I start when this topic comes up for discussion is we need to recognize that not every single patient is an ideal candidate for extended half-life product. So I think that's an important point as a starting place. I think ideally decisions about a patient being on an extended half-life product are driven by pharmacokinetics. So we want to use pharmacokinetic testing to identify those patients who have a PK profile that lends itself best to the benefits of an extended half-life product with an extended dosing interval. So that really should be the basis of the decision making here is considering each patient's individual PK. In addition, some other variables, I think probably the most important one next on the list would be the patient's activity level. So for example, some of our patients who are still physically very active, some of these patients actually may be better protected on a standard half-life product given more frequently because they need those peak levels on a more frequent basis to give them bleed protection. So for in that situation, then an EHL product may not be the best fit. So PK, activity level, certainly venous access is an issue, and how all of these things translate into adherence. So really this, I guess what I'm saying in a long-winded way here is this is a very complex decision-making process with a lot of different variables to consider. I think the ones I mentioned are the key ones. The other thing I would just add here is that this decision that's made is one that needs constant reevaluation. We know that as patients go through different stages of life, the set of variables that dictates what the best regimen for them may change. And so a constant reevaluation of that regimen, making sure that it's still the best fit for this phase of life is a really important thing. And then just lastly, I'll just add here that if this is done properly, overall, this is cost effective. So we want to make sure that we're matching the regimen as best we can with the needs of the patient at that given point in time. And if we do that, I think the way I say it often is the most clinically effective care is going to be the most cost-effective care, and I think that really applies to this whole topic of considering which type of product for a given patient.
And would there ever be any hypersensitivity reactions in the use of the extended half-life product that would then prompt moving back to the standard half-life, or in moderate to severe hemophilia A?
I guess it's a theoretic possibility. I don't think that we really see that as a practical issue, though. I will say, as a disclaimer, my experience is somewhat biased by being an adult treater. We don't see young children in our center. We just see adults. These hypersensitivity reactions generally are an issue in the youngest children, and so the pediatric providers may have a slightly different take on that. But they are rare, and I don't think there's great data to really say that it's more likely to happen with one product than another. And so I don't think that's a huge variable in our decision making, actually.